Good afternoon. Oh, wow, okay. I like that. Okay, so today we'll be talking about kind of the newer procedures that we are doing here in the lab from a peripheral perspective. Which of these buttons we press? As well as renal denervation. So I understand that not everybody here is familiar with the kind of things that we do in the cath lab, and this is an even further subspecialty looking at strictly just everything that happens in our endovascular division. So I'll definitely begin by giving a little bit of a basic background as far as what it is that we do for our endovascular patients who have peripheral arterial disease, and then eventually also be touching upon the newer procedures we're doing involving renal denervation. So we'll be talking about critical limb ischemia, very complex long femoral popliteal lesions, as well as the two new devices we have out that are FDA approved for renal denervation. So let's get right into it. I have a lot of slides. So what is critical limb ischemia? Glad everybody had lunch already, but basically once you have blockages in the arteries, that's, you have very symptomatic pain on ambulation. That's claudication. As that progresses, you get to the next step, which is where you develop rest pain. As it worsens, you can develop non-healing ulcers, gangrene, and eventually this can lead to amputations. And in the U.S., we still, despite all of our work, still have, over 150,000 annual amputations due to CLI. And the reason why this is so important is because there's such a strong association to mortality with CLI. In fact, the only other diagnosis that carries a higher mortality associated with it is actually lung cancer. After lung cancer is CLI, and then again other cancers. So clearly, no matter all the the talks and devices and all the stuff we have, CLTI is still translating to a very high mortality, not only in this country but globally. Now that being said, let's just say you have these patients who have CLI and you start to do stuff to them, whether you do an endovascular revascularization or a open surgical revascularization. What happens with these patients compared to those who end up getting a primary amputation? And amputation is actually what a lot of people actually end up getting, and this is also associated with a very low survival rate, lower than both of the other interventional and open surgical options, as well as the overall financial burden on the healthcare system. Now, we've had a lot of trials looking at what it is that we can actually do for these patients as far as different kinds of balloons, drug-coated technologies, different kind of stents, and so far they all kind of suck because there really is no real true data that's showing that there's actually anything that we can really do that is supported in a randomized controlled fashion. And there are some caveats why perhaps some of these studies did not actually work out the way that they were supposed to. Maybe the balloons were too small. Maybe there are some basic differences in the architecture of the vessel, or maybe the balloon angioplasty we were doing, maybe that's not actually as good as we had really thought. So Abbott came up with the Esprit balloon system, and this is basically taking a little bit away from the coronary bioresorbable stent, where basically there's a bioresorbable scaffold that is covered with a drug, in this case is everolimus, and this scaffold over time basically is going to be absorbed into the vessel wall. So you have a 3-month period where you have some absorption of the actual drug that eventually goes into the vessel wall, giving you your chemostatic antiproliferative effects to prevent in-stent restenosis, and then you have a scaffold that physically holds the wall of the artery open, and over time this scaffold goes away because if you don't have a scaffold you can't really get in-stent restenosis. So this trial eventually wound up in the New England Journal of Medicine, which usually means that it's a pretty good thing. And this was actually one of the first ones that really did show that there was actually an absolute risk reduction in a below knee treatment modality compared to PTA. And there was roughly a 31% risk difference between those who had actually ended up getting this bioresorbable scaffold versus just standard PTA. And remember, PTA as of right now for below knee treatment is actually what our standard of care is. And not only was it showing that the primary efficacy endpoint, which is the composite of the limb being saved and the vessel being opened in terms of primary patency at 1 year, not only was it just effective, but it was effective in the lesions that we know do the absolute worst, which is the long lesions. So even as the lesions get longer, this bioresorbable scaffold still did a very, very good job in terms of keeping the artery actually open. And this is a case, we'll see if this opens up, was one I just did not too long ago. This is a diabetic smoker who had, less than one vessel runoff. He had this ischemic rest pain. You see this very, very tight lesion right over here. And then this is the post picture. You can't really see too much because, again, since this is a bioresorbable scaffold, you don't see the stent the way you do up here and below. But there is a scaffold right over here, and look at that. It looks fantastic. So now another end of critical limb ischemia is actually something known as no-option limb ischemia. And again, people who found themselves in this unfortunate situation have very, very high rates of amputation, death, poor wound healing, and again, there's no real study that can really show that these patients actually do well. So what is no option CLI? And that's basically what this is. You can imagine that if you're trying to open up a blocked artery, you have to see kind of where to open up into. A no option is also known as a desert foot, where basically there's no nameable vessel in the actual foot. And this can happen for a bunch of reasons, very bad diabetes, you have some microvascular issues, but the case in point is that no matter what you want to attribute the reason to, these patients do the absolute worst. There is a new device that was created not too long ago. It was piggybacking off of a previous concept that was done, but now it was a dedicated device to it. And this procedure is known as a transcatheter arterialization of the deep veins, TADV. The previous name of it was DVA. It's a little easier to say. But basically the idea is that you accept the fact that your native artery is entirely blocked, but there's a healthy vein running right next to it. So you just create a tunnel from this, from that blocked highway to the vein. So the way that it basically works is this is a dedicated system where basically on one end you have a device that goes into the vein, one device that goes into the artery, and you basically just bridge the gap, you connect the two, make a tunnel, and then you provide flow, oxygenated blood flow through the venous system. So this is just very briefly going about how the device actually works. So you see you get some venous access down on the foot, and the catheter that you have in the artery basically lines up with what you have in the vein at a point where you're going to make this fistula, essentially. And the device has all their fancy things where basically you can send your wire directly into the venous system. There's a valvulotome that you also need because if you remember, these veins also have these valves that prevent the blood from refluxing with that it would assume to naturally. And then it also comes with a self-expanding stent system that goes all the way up from the access site all the way approximately to where you had crossed from the vein onto the arterial side. And then at the very end, you see this, where basically you get arterialized blood flow going through the venous system, and then you have this little blue being another representation of your venous circulation from the other tibial vessel. And this is a case that was done, and again, just for understanding, this is what, man, how do you go backwards? Red. Good. So this is a normal foot. You see these nameable vessels. You may not know what they're named, but I do. This is again, a desert foot. And what we see here is that this is basically what you get immediately afterwards, where now you've accessed all the way down to the venous system down to the foot, and you've created this channel, this tunnel that basically is covered from the foot all the way up, and you see now all these veins that were previously not even lighting up because you'd never really gained access to them are now the ones that are feeding blood from an injection coming from the top all the way down below. And the good thing is that this actually lasts for over a month all the way to about 3 months, which is essentially all you really need for a wound to be healed. Now, from the PROMISE 2 trial, which was published showing this actual device, limb salvage rates were tremendously improved at 6 months, a 75% rate of limb salvage that only went down another 7 or 8% at 1 year. It's pretty impressive for these patients who don't really have much of an option. And that was just in terms of limb salvage. Now, in terms of wound healing and completely healed, you saw that there was at 1 year, there was about 92% of the wounds that were healed or healing. About half the patients had complete healing. The picture on the right is kind of showing how they had, used some funny terminology to differentiate a healing wound. And that's just basically the fact that even if you have a small eschar, even that is counted as a healing wound. And you see eventually at 1 year that these wounds are completely healed. They also have a significant reduction in their pain, obviously, because you can imagine if you don't have any blood flow to your foot, that's incredibly painful. So a lot of these patients at 1 year actually present at a Rutherford grade 0, which is one of the most accepted grading scales for claudication, and all the way up to critical limb ischemia, ischemic rest pain, so on and so forth. And these patients have a sustained improvement in their case. Now, here's a case of a TDB that we did. There's also a patient who had an amputation that was not healing very well. And again, you see the initial pictures where there is no real flow in the foot, and then you have this great revascularization into the venous system, and then you see over time this wound is slowly going away, away, away. And without this wound would have never really healed. Now, the question is, how long does these venous conduits really stay open? It's hard to really say. It seems as though with this device, it seems to be doing a little bit better than the previous, the ancestor of this was just a ad hoc, off-the-shelf DVA procedure, but everything is looking pretty good in terms of the sense that these patients are achieving the goal that is as acceptable as we would really accept, which is essentially just wound healing, limb salvage, and improvement in their rest pain. So now we're going to leave the CLTI. So now we're going to talk about people who have pain when they walk, right? So these are just patients who have intermittent claudication. And we've kind of already spoken about this, but intermittent claudication is basically the step before you present where you have pain completely at rest. Now it's people who have pain when they walk. And as you can assume, if CLTI is very underdiagnosed, so is PAD, as it is undertreated. And there's still a very high mortality associated with this, again, not directly from this diagnosis itself, but with this associated diagnosis of high cardiovascular risk. And these lesions where you have long, complex femoropopliteal, heavy calcified lesions like 20, 30 centimeters, these are ones that are actually really hard to do. So your options are two things. Either try open surgical bypass, which is one that works very, very well, but again, these longer bypasses are a little bit more challenging to do, longer hospital stays. Then you have your percutaneous options where you can do all the different forms of atherectomy, stents, and anything really. But the more complex it is, the higher rates of failure. And then regardless of all that, if you do an open bypass, the risk of infection has been reported to be quite high, as well as a very long length of stay, because this is a pretty big surgery. And if you choose the endovascular approach, there's a re-intervention rate at almost 25% at just 1 year. So that's not really ideal for these very complex lesions. So what is PTAB? PTAB is basically a percutaneous transmural arterial bypass system. This is made by now by Endologics. And basically, this device is created to basically kind of very similar to the previous device we just spoken about, but basically using the vein as the conduit. But instead of staying in the vein, you exit the artery, go into the vein, and then re-enter back into the artery after the blockage. So this is a very brief example of it. You can see that you have your artery here, this is your blockage, and this is your vein running right next to it. So now we're just taking advantage of one's natural, normal anatomy. And the vein is running right up next to it so that you make a connection between the artery and the vein, bring the wire all the way down, and now you basically have a wire going through an artery, past the blockage in the vein, back in the artery after the blockage, and then you just connect everything. And this procedure worked great. There's a success rate of almost 100%. The patency of these patients is very, very impressive, in the high 90s, all the way up until 2 years. And revascularization was tremendously low at even 1 and 2 years. Primary system patency and secondary system patency, both of them were all very, very low. And this is a case that we had done here. And you can see that in this case, there's a stent here. I don't know if you can see it, but it's not there. It's closed. So then this is where it reconstitutes right above the level of the knee, right around here. So what you do is that you make this connection. This is after all the work has already been done. And then you see that this connection is now actually a covered graft that is in the vein right next to the artery. And then you see it again coming back out. Down that same vessel, you see it right over here. So, good. Now, last few minutes. That's good timing. Now we are going to talk about renal denervation. So blood pressure control is one that no matter how hard we try, we always do a pretty bad job. There's lots of different types of modifications we can do, but the case point is that still, no matter all the work that we do, we still have a lot of patients who are simply just uncontrolled. And the controlled population is less than a quarter, which is, that leaves almost 90 million patients in the US alone that are considered uncontrolled. Now, this has actually been getting even worse in the past few years. And it's hard to really say what the etiology of this, but at the end of the day, the point is that we're not doing a very good job at controlling it. Now, why is it so important to control blood pressure? And that's really because with each incremental decrease in your systolic blood pressure and diastolic, over here we're only looking at the systolic, there's a major reduction in all of the cardiovascular risk factors, in major cardiovascular death, stroke, heart failure, ischemic heart disease, across the board. The difference between just 5 millimeters of mercury versus 10 shows, as you can see, a tremendous drop in all of these major risks. And you can see that this, this non-adherence is really a big issue. Even if you look at people who have just partial non-adherence, where they're just not taking all their medications, that's at 44%. People who are not taking anything is all the way down to about 17%. So again, there's lots of room for improvement. But that being said, there is a new kid on the block, kind of new, but we'll talk about that in a second. The way how renal denervation works is that there is a sympathetic nerve activity that is controlled from the brain and the kidney arteries around the nerve bundles that surround it. And the idea is that if we stop this connection, we decrease the overall sympathetic tone of the brain and the kidneys, and thereby we're removing the kidney's input on driving sympathetic activity to increase the blood pressure. So now, a little bit of science. This is your aorta. This is your kidney. You see here all this yellow stuff. This is basically a human renal nerve anatomy, and you see that you have these ganglia very proximally close, and you have these plexuses a little bit further out. Now, this is important because this difference in understanding is kind of what it differs the two different treatment strategies that we really have. And you can see that proximal to the aorta, there are these big ganglia, but these little tiny yellow lines are the smaller nerve plexuses, and they arrive a little bit later on. And the two devices that kind of are available, which is the Spiral Simplicity and the Paradise ReCore ultrasound renal denervation device, these two differ in their basic understanding as far as which of these nerve systems have to be actually targeted. So briefly, the two devices that we have. The Simplicity Spiral renal denervation catheter is one that looks literally just like this. It's a little spiral, and it uses radiofrequency ablation, and it has these 4 little gold dots that get super hot and basically send just through radiofrequency and burn late arriving nerve plexuses. So the goal for this device is to go as distal into the artery as possible, target the nerves that are closest to the actual kidney parenchyma, and do a little bit more proximally as well. The Paradise system is actually one that's based off of ultrasound, that actually targets mostly the proximal renal ganglia and the nerves. And the idea here is it uses uses ultrasounds to kind of disrupt these nerves functioning, thereby again decreasing the overall sympathetic tone that is brought by these devices. By these nerves. There's a little bit of, I don't know how anatomically savvy everybody here, but the nerves run in the adipose tissue around the actual renal arteries. So the difference is kind of like how can this energy be delivered to wherever these nerve bundles or nerve ganglia or plexuses are without disrupting everything. And that's basically the main reason why these two differ in their overall technology. Now, RDN, I said before, was something that is not really new, but that's because it's not. It actually has been here for quite a few years, but it did a very, very bad job in their landmark trials. In the Simplicity Hypertension 1, 2, and 3, they basically saw that the people who had the sham control, as in had a procedure but no procedure done, as in no renal denervation done, they just got a lot of good medication and they did fantastic. So that kind of closed the door on this for a while, but there were a few companies that kind of kept on pushing through. And eventually we had these 2 trials from the Simplicity looking at the spiral hypertension off med. We're not taking any medication that showed a persistent decrease in the overall systolic blood pressure readings at home and in the office. And this was a sustained benefit that was kind of continuing for the entire period of the 24 hours. That compared with the sham control also did very, very well. We saw that even the 24-hour readings also did very, very well. On medication, again, an even more improved benefit. The Paradise Recor also had 3 other studies that also showed very, very similar benefits that was sustained over the 24-hour period. So a few key takeaways. For the CLTI cohort, there are 2 basic new procedures that we can really offer. One is this bioresorbable scaffold that can help these patients improve their symptoms and wound healing. The limb flow is another good option for our no-option patients. PTAB can be used for patients who have these long, complex CTO of the ephemeral popliteal segment that traditionally do very, very poorly with endovascular and surgical bypass. And renal denervation, although it's new again, is going to be our new frontier in resistant hypertension management. And that's it. Thanks.